Hey guys, this is Dr. Mahajan from Mahajan Medical Center. Very excited with another webcast we're going to do today. We got a very special guest today, and she's going to bring a beautiful perspective about palliative care, hospice, end of life, advanced directives. Her name is Jasmin Marte. Dr. Jasmin Marte has wealth of experience with palliative care and hospice. She's the medical director. I think yesterday's webcast, I said she's chief medical officer, and she corrected me. She said she's not the chief medical officer. She's not a paper pusher. She's a real doctor. So I stand corrected. So she's the medical director for hospice in Pinellas County. Um, for those who don't know me, I'm a board certified internist, and we do once a week webcast on various issues which are important to our patient and public at large. And we've been very successful in getting our message across to different communities about different issues over the last 6 months. And especially with the COVID era, we've a lot of our patients and public at large has found it very successful and useful to have some real news instead of fake news. So that's very excited about that. All right, so let's just say why we want to talk about hospice, why we want to talk about palliative care. Let me bring a screen and share that with you.
Hi.
Yeah, we'll get you in a minute, Dr. Martin. Let me. I know you. So why are we discussing hospice today? What lies ahead. Okay, here we go. So there are a lot of chronic conditions which we all have in geriatrics, and they are important to know that they can limit the life expectancy. And we'll go in at length of different systems, and and before that, as you're getting older, and you may need to bring up your primary care physicians. Why we need to continue with aggressive treatment at a certain point in life, and is it going to help us, or is it going to just make us more miserable going from various specialists and getting aggressive treatment? And if that's what you want to do, the aggressive treatment, and that's your personal choice. But if you not satisfied with going for imaging and one specialist and to other specialists, getting every other week in the hospitals or dialysis center or chemotherapy or whatever it could be, I think palliative care is a good step down at that point, and we'll have Dr. Martis talk to us about how that can help. That doesn't mean that you're dying or something, but definitely you're dwindling, and you need other options included in the discussion. And I think palliative care is a good fit there. So let's just quickly go over the top 10 causes of death in the United States. As you can see on the screen, it's almost a tie between cancer and heart disease. No wonder every webcast I talk about heart, and that's one of the reasons, because it's the leading cause for mortality. And there is more you can do about preventing heart disease, and maybe cancers also. There are some cancers like breast cancers and cervical cancers or colorectal cancers, where you can do early prevention, but there are some cancers you can't do a whole lot. But at least with the heart disease, for sure, if you do lifestyle changes, and we talk at length about different interventions with exercise and diet, and that's why I do that every time, folks, because it's the number one cause for death. And then you can go down the line, and there are chronic lung disease and strokes and dementia, diabetes, influenza, pneumonia, chronic kidney disease, suicide, and maybe COVID will fit in somewhere there for unfortunate pandemic here as well. So let's get Dr. Martis up on the screen and talk to her.
Hello. Hi.
Yeah.
Thanks for having me.
Thank you for coming. So Tell us about yourself. I know you're from originally from Dominican Republic, a beautiful place. It's on my bucket list to go. So you are in Virginia. So tell us how long you've been in Florida and where you were trained and how you got into hospice.
Well, thank you. My background is in internal medicine, and you can call me a full-fledged patient-hugging doctor. So definitely not a patient paper pusher. Yes, I am originally from the Dominican Republic, and I did my training in internal medicine here in the United States, in Virginia, and stayed there for about 10 years. And now here in Florida for the last six, five of those practicing hospice medicine, which I love.
Okay, great. And what you love about hospice medicine?
I think it's very empowering to see that the patient drives the treatment. It's a very patient-centered kind of care. Anytime we talk to a patient about hospice or a patient is enrolled into hospice care, the first conversation is around what are the goals of care and what the patient wants for themselves, or in the case that a patient cannot make those decisions, what does the loved one or the caregiver wants for their patient, taking in consideration their values. So that is very powerful and something that is very unique to hospice care.
That's a great point, Dr. Martis. And um, give us in last few weeks, give us an example what made you think, thank God I got in hospice. That's the reason I should be in hospice and I should not be doing this dirty primary care.
Yeah, I wish that I didn't get goosebumps when I get that question, which I do get often, but it's every time you think about a special case, almost like everyone is special for sure. We have had a significant impact in families, for families and patients dealing with COVID-19. And we had a patient who was very ill in the hospital. In his family, this is his young children in their teens and 20s, have not seen him, and he needed to be extubated, so terminally extubated, as he had been in the ICU on life support. Because of all the restrictions in the hospital, only his wife had seen him in all that time. When the decision was made to proceed with removing life support, we brought him to our care center, and we made it happen for them, where the entire family participated in his last hours of life, thanks to being in one of our care centers. It almost makes you feel like a Make-A-Wish Foundation, in a sense that we do make these things happen because we know how important they are for those that are left behind, as much as they are for the patient.
That's a great point. Let me bring a comment we got from Stephanie. Uh, Stephanie just put a comment saying that both her mom and dad had hospice and they were great for both her parents and they were there for her too. And I think that's a great point, Stephanie. Bring. Thank you for watching, Stephanie. But yeah, as you know, and we were discussing before this talk that I've been doing it for 25 years. So, I see a lot of geriatrics because I'm a medical director at a local rehab, and I see the whole spectrum of the families. That means I see the parents, like Stephanie said, and then I see the grieving children. And I think we don't bring up a good service, the great service the hospice does is for the family once their loved one has departed in terms of the grieving counseling. So I think that's another reason to have hospice, even for a short period of time, to get the family exposed that they have support, professional support, which won't cost them anything. Touch a little bit on that, Dr. Marcus, please.
Yes, and that's a great point. Unfortunately, many people do not take advantage of the hospice services. And although it's a service that is built for patients who have a prognosis of 6 months or less, the average length of stay in hospice is about 54 days. But that is driven because a lot of patients come to us at the very last even hours of life. But even then, we can make a huge impact, not only for the patient and how things will happen for these patients in their last hours or days, but for those family members and caregivers that are left behind that will need the support of bereavement counseling, which we provide all the way through a year after their loved one is gone. And then after that, we can help you engage into our community counseling services. But completely free and included in our hospice services is that 1 year bereavement that you will receive once your loved one is gone.
Let me ask you this. Let's say, someone didn't use the opportunity, and they died in the hospital, and we're seeing a lot of that with COVID. Can they still utilize hospice service for bereavement counseling?
If the patient associated with that person, that family member, or that loved one, and sometimes even very close friends, was indeed admitted to hospice right before passing, yes, those services will be available. If that did not happen for many circumstances, sometimes it just didn't happen in time, we do have community counseling services, and these days they are even being offered via telehealth. So there are opportunities where people can engage with Empath Health, community counseling services, and receive those bereavement visits as well.
That's good to know. And, that's because we're seeing with the pandemic, a lot of people, losing their loved ones across the country. And if they're on Pinellas County, so they can call Empath Health for, bereavement counseling, because, it's important to give a virtual hug in this difficult time. While we are on COVID-19, and it's brought some special circumstances for hospice, which you guys were doing 6 months back, and I was looking through the services you're providing to the families or loved ones who have COVID-19. Walk us through how the services have changed or become more broader with COVID-19.
Absolutely. It's certainly something that we were facing at the same time that everybody started seeing the consequences of this pandemic. And one great advantage of having a patient connected with hospice, especially if they are within facilities, which, as you know, have restricted quite a bit the visitation, especially at the beginning of the pandemic, we were able to be one of the very few staff members allowed into the facility to see your loved ones. And then from there, we were able to bring iPads or iPhones and help the family communicate and see their loved ones as they were not able to come in the facility. So that was a huge thing that connected a lot of people. We did that also from our care centers and from all the places where we were servicing our patients. We also were available to go and see in-person visits in the community for those patients that we care for at home, and also telehealth visits for all of our patients. So that really expanded the access to the care that we provide through physicians, nurses, clinical social workers, counselors, and spiritual care coordinators or chaplains. And as always, we have our home health aides, which are an essential piece of our interdisciplinary team that have helped quite a bit of families with their loved ones and giving them that, bathing, getting them ready for the day, and so forth. So we've been an integral part of this COVID-19 era and have sort of figured out how to manage it and still provide the services.
That's great. Let me bring another comment up here. It's a personal friend, and it's sad. So Anju is saying that her dad was in hospice, and it was hardest time their family went through, and it took her a long time to cope with his death. And grief and bereavement for loved one is very difficult. And the hole left by your parents is never filled. It's just that you just get to learn to live without them. But yeah, thank you for sharing, Anju. I know it's a difficult thing to share, but it's good to get that out. I think it helps other people that they're not alone in this grief. So it's good to for everyone to be honest about their, everyone put a brave face. How you doing? We're doing great, but deep inside they're suffering. So it's good that you guys offer those services. Let's bring other thoughts for the hospice. I know there are a lot of conditions common conditions where they could be. You want to talk about palliative care first in that order, so that way, we talk more than 6 months and then less than 6 months in that order. Uh,
Yes.
okay, so
Yes.
talk us about indication. What is palliative care? In what scenarios a physician or family should think of palliative care, Jasmine, please?
Right. So we know that hospice services are provided under Medicare and other insurance, including Medicaid and private insurance. And it is for patients whose prognosis is 6 months or less, based on the physician's clinical opinion. But for those patients who are not there yet they're dealing with chronic illnesses, heart disease, lung disease, or cancer that is advanced but not quite advanced to be in the last few months of life, liver, kidney, they can engage with palliative care services. So sort of a little bit more of an upstream service that provides assistance with managing symptoms like pain, either, neuropathy, arthritic pain related to a cancer, breathing difficulties, even heart conditions that require quite a bit of medication adjustments. And imagine that you have this provider that is helping you navigate this very vast medical arena where you are seeing so many different specialists trying to help you in care for your health. This person can help you communicate with these different attendings, these different physicians, in trying to coordinate your care so your symptoms ultimately are better controlled, as opposed to having 3 or 4 physicians throwing medications at you and not talking to each other. So they help coordinate that care quite well, but they also intrinsically also operate with the hospice philosophy, which is also understanding what your spiritual needs are, what your psychosocial needs are, understanding if there's going to be significant grieving just because of you dealing with a chronic illness and so forth. So it's a very integrated type of care. It can be offered in the hospital setting when somebody's really ill at the hospital, or we do have in Empath Health a community-based palliative care service that does go to the patient's home to provide the services there.
So that's good to know that, a lot of myth out there that hospice, Dr. Martes, is only for when you're dying. As you said, most of the people use it like a day off or, even a few hours off, which is such a shame because you guys have such beautiful volunteers, and they have, very dedicated lifestyle, and the patients can relate to them. They're not
Yes.
they're not pushing any agenda other than, from goodness of their heart, they are there. Tell us about the volunteer program. If any of our listeners are interested in doing the volunteer, what kind of program you have. And I know you guys have about 2,000 volunteers or so currently.
We do. We have a significant amount of volunteers, and they come from the younger ones because we do have a team volunteer services, to adults that simply want to add something really meaningful to what they do in their lives. Some of them are working adults, some of them are retired. Our volunteers service in all the aspects of our organization. One very popular area to volunteer is our care centers and sitting with our patients when they're critically ill. In our care centers, our patients are there because they have very intractable symptoms. So it's a very vulnerable time, and our volunteers sit next to them. Some of them are called transition volunteers, so basically spending time with a patient who's dying without a family member next to them. We also have volunteers that do fun stuff like go shopping for our patients or walking their pets. We even had one feature on the news the other day, this young mother that she goes to a couple's home, both of them in hospice, and she does some cooking for them once a week. So there's a lot of fun opportunities, and for the team volunteers, there's definitely many opportunities to provide assistance to our patients, like doing legacy videos, where our patients can have a recording of anything that they want to leave in video for posterity, and they take care of that. They also do birthday parties for our patients. So there's a lot of great opportunities for our volunteers in the community.
That's good to know that the volunteers have so much diverse opportunity, and everyone from different walk of life can contribute and help fellow human being which is going through with their loved one, going through chronic conditions or end of life or death or not having anyone next to them. So it's good to have a human touch and have some dignity. Let's bring couple of slides up here. So, you have this slide up in your thing called "Is my condition under control?" And let's see, what type of question should you ask your healthcare provider? You suffer from chronic condition. That's good. So let's see. Here we go. No, we're going in the wrong order. Here we go. What are the natural course of the disease? And you have a nice graph about dementia, Alzheimer's disease, how from preclinical it goes down quickly to mild cognitive impairment to the dementia and then, demise. And while we're on the topic of dementia, Jasmin, let's get your expert opinion. And in Pinellas County, we have, unfortunately or fortunately, very, a population in their 70s and 80s. And as we get older, as you know, the dementia get more prevalent. So what are the various indications for, let's say, of course, the patient with dementia, they can't help it. It's the loved one, the caregivers who has to make that decision for them. What's the time frame? I know you have different criterias and parameters and some scientific scales. If they are 7A, B, C, D, E, a FAST scale or something like that. So walk us through if someone has dementia, at what point they should start thinking of palliative care and what point they should start thinking of hospice care.
Yeah. Definitely when you are dealing with a loved one who has any type of dementia, and as some of you may know, Alzheimer's is the most prevalent type of dementia that exists, but there's also the vascular dementia that happens in patients who have had strokes or mini strokes or vascular disease. And there's some other dementias like frontal dementias and so forth, the one that is associated with Parkinson's, for example. So any of those dementias that starts entering in a stage where the patient becomes heavily dependent on their caregivers for the day-to-day activities is a dementia that is considered advanced. They can no longer dress themselves, or they have difficulty feeding themselves, or they go to finger foods only, or they start to having like issues with infections, maybe not eating too well. That's a moment where you can start discussing how does end-of-life care looks like here. And by end-of-life care, I don't mean that patient is necessarily in the last 6 months or last year, but it's certainly a disease that has a trajectory that, can quickly evolve into the patient's passing. So you have to be ready, you have to bring services. One of them is palliative care if the patient is considered not to be in those last 6 months of life. But let me define when we consider a patient to be within the last 6 months of life once the patient is diagnosed with dementia. If a patient, as I mentioned before, is already depending on their caregivers for all activities of daily living, bathing, dressing, eating, and is mostly either chair-bound or bed-bound, that's a patient that hospice could come and evaluate for potential admission. If the same patient is already losing their ability to speak and doesn't speak more than maybe 6 words in a day, and they don't make sense, at the same time that they're deteriorating, like I mentioned, that's a patient that could be eligible for hospice. The same patient that is having difficulty swallowing, losing weight, so is having trouble with nutrition, frequent hospitalizations for falls, for infections, or dehydration. Any of those conditions definitely should prompt that family member with that patient with dementia at home to call hospice for an evaluation.
Yeah, that's great points you brought, and thank you. Let's move on to cancer. I know that's head-to-head with heart disease, and we'll go to heart disease after that. But cancer brings the hospice traditionally in people's mind. So let's take the beast by the horn. So in cancer, you go by a particular scale, and walk us through what does less than 50% on that scale means when they should start thinking about hospice care, or where does palliative care fits in with cancer?
So it is recommended to involve palliative care services from the beginning when a patient is diagnosed with a cancer stage 3 or 4, meaning a cancer that's not only confined to the original place, let's say it's not only on the kidney, but it's already go to the lymph nodes or some part of the abdomen. and definitely in a patient who's in stage 4, which is the cancer has sort of left its place and sort of spread through the body. But when that patient who has cancer is undergoing treatments and those treatments starting to look like they're no longer working and your oncologist is already discussing, maybe stopping the treatments, that's the time to call hospice, because then you're considered to be within that 6 months or less prognosis, depending on the type of cancer. And the advantage of having hospice involved from the beginning of that stage where, no longer aggressive treatments are pursued is so that you can have all that interdisciplinary team support at home. You can have those frequent nurses visits to assess all the symptoms that will come with your disease, a physician that can help manage those symptoms along with your physician who is treating you. Also, that support around with your family, and including your family by the counselor and the chaplain. So there are a lot of advantages of having that kind of interdisciplinary team approach to a patient who has advanced cancer that hospice can definitely provide. And before that stage, again, as I mentioned, if the patient is not quite there, where they're still receiving treatments, they're still sort of going for chemo or radiation or having immunotherapy going, then definitely have palliative care involved. So those services that are similar to hospice can be provided with frequent visits from a nurse practitioner at home, to pain management, to also spiritual care or counseling.
That's a great point. Let's bring a comment from Shawnette. Shawnette said, Suncoast Hospice is always here for you, and that's a great point. And they've been here since 1977. If my memory serves me well, they were started by volunteers and to fill up in a void we had in Pinellas County, and they have been doing a fabulous job. Now they are under the umbrella of Empath, but still non-for-profit, correct?
That is correct. So we are still a non-for-profit organization, very proud, over 40 years serving our community, definitely above and beyond, and proudly.
Yes. Let's bring another condition into play here, the advanced heart and lung disease. And, as you can see, the congestive heart failure is right on the top. And we see a lot of patients suffer with fluid buildup and leg swelling and unable to breathe. And same thing with similar symptoms with COPD. They have, you tried the oxygen and they have inhalers and bronchodilator treatments, and they're still not able to get their air in. And they had frequent hospitalization, 3 or more in a year, or more than once in 3 months. So walk us through how the palliative care, Jasmin, or hospice care fit in these kind of common conditions.
For sure. And thanks, Kathy, for that message. She says you used to be a hospice nurse. I think you're always a hospice nurse, once a hospice nurse. You have that heart. So yeah, for patients with chronic conditions like congestive heart failure and COPD, emphysema, or chronic asthma in a very advanced stage, hospice comes in when those conditions, in spite of medical treatments, they are not responding well. So we do have a subset of patients with congestive heart failure who are maximized, meaning they have received all the available medications in the market to try to keep their heart failure under control. They may not be candidates for heart transplant, either due to advanced age or because there are many other conditions other than the heart that are affecting them. So when they come to hospice, we try to do both things. We try to keep them on the maximized medical treatment so that their heart function remains as best as it can. And then we add a specialized care, including medications, to ease the breathing and to ease the sensation of suffocation, of palpitations, of tremors, and other things that come along with that heart failure. We also admit patients who come to us with ongoing drips just because they are the ones that are sort of keeping things at bay. We accept those patients. We accept patients with LVADs, which are machines that help the heart pump, but we know that this patient's still failing. So there are complexities within a heart patient, but we certainly try to work with all of them as far as they are sort of towards those last few months of life, because we definitely believe that having your end of life with hospice is of great value for you and for your loved ones. And the same situation with emphysema, COPD patients who suffer a lot of suffocation, difficulty breathing, panics, and anxiety because of that condition. We bring them, we maximize the medical treatment. I cannot tell you how many times once they come to hospice, because of how we utilize the medical treatment of these patients and the intensity and how we use it, they end up getting better. And it's not unusual for patients to graduate from hospice because simply we sort of take them away from this cycle of hospitalization, rehospitalization, take care of them at home intensely, control the symptoms of anxiety and what triggers them to go back to the hospital, and they get better. So, it's a lot of advantage to having these services on board.
So that's a good point you bring, that, you're not only taking patients which are dying, you're making patient better. So the internal medicine training comes handy then.
Yes. Oh, yeah.
Yes, Kathy Hyde is a very special patient of ours. She not only been a hospice nurse, she has been going to all the hot spots in the world, and she goes and volunteer and help patients in need there. So she's a special person, and she is, she's big heart, as you said. So she does have a bit. Thank you for watching, Kathy. We love you.
Thank you.
All right. So let's talk about another condition which is very common and complex. And most of the conditions are common and complex. Unfortunately, we're living longer and we have technology tethered to us. So one of that is end-stage kidney disease, with technology tethered left and right. And, I was talking to Dr. Shete, who's a good friend and a good nephrologist, and he was saying that once they get on dialysis, the life expectancy is 5 years, give and take few. And that's just difficult, and plus the amount of suffering they go through every, Monday, Wednesday, Friday, or whatever their schedule is, 3 days a week. They're sitting for 3-4 hours in a dialysis center, and that drains them out. So that's a seriously difficult condition. And then plus they have acceleration of their coronary disease, and they have more infection. They're in the hospital every month. It's a seriously, complex disease management. And, if you don't do it, then you die. So it's a very, difficult condition to say, okay, what's good or what's bad. Hopefully they're younger and they are, get a kidney transplant and don't have to be on dialysis for long. But walk us through how hospice or palliative care work for end-stage renal disease, Jasmin.
Yes, so patients with end-stage renal disease, as you mentioned, they do have a life-limiting condition unless they were to benefit from a kidney transplant. But as I mentioned before, for example, with advanced congestive heart failure, not all patients are candidates for that because of the many other comorbid conditions. They may have other diseases that prevent them from going through something like that, or simply because of the advanced age. So they are warriors for sure. They go through years of a lot of treatments and hospitalizations and clogged fistulas and you name it. So some of them just simply come to the conclusion that, as their body is deteriorating, going through all these, that they decide to stop the dialysis. But that is something really hard to do cold turkey and just go home and pass. So we definitely make that process something that is a lot more compassionate. Right. So once a patient decides to forego dialysis and they come home, we are going to make sure that the medications that are needed to keep them comfortable, where they don't feel like the fluid's building up, that they are feeling out of breath, or that there's itching, or there are other things that can come along with discontinuation of dialysis, are bothering them as they would. And then there are the patients that I mentioned there who are dialysis patients that are just, slowly deteriorating. And based on clinical criteria, we still think that they may have about 4-6 months to live. So still within that hospice window. And they still go into the dialysis treatments, 2-3 times a week. They can go by car. They're not like bedbound or anything like that. Some of those patients we do bring in a hospice and don't discontinue the dialysis until they're ready to do so. So have in mind, as I was discussing with you, Dr. Mahajan, dialysis patients die like everybody else. And we want to have them be at ease and at peace when they make the decision to finally discontinue. So we definitely work one-on-one, case by case, to see what's best for the patient. Going back to what's beautiful about hospice, which is very patient-centered and very much following the patient's goals of care.
Yeah, that's a great point. That a lot of people think that you're putting someone in palliative care and you're preparing them to die, and sometimes, yes, sometimes you got to accept the reality, and it's hard. But sometimes they may not die, and you help them with comfort, and improve their underlying nutritional status and emotional support and other issues at home. And sometimes they may get better, and they may become a, let's say in case of end-stage renal disease, they become a better candidate for kidney transplant. So
Right.
we need to accept death as we accept birth of a grandchild or a child. The death is going to happen to all of us, no matter what we do. But it's a difficult issue to absorb. And and hospice organization like that, and a lot of other spiritual organization help people understand and deal with death better. And while we're on topic of death, let's just get a very important topic I discuss with all my seniors first time they come in to my office. Jasmin, is advanced directive, and I think
Yes.
advanced directive is very critical. Once you get to a certain age where your mortality will come, and 60 plus, 65 plus is a good number, and it's a difficult topic for anyone to address that they think is not going to happen to them. But it's good to get your living will done if you want to be DNR, or if you want to be organ donor. Get that all out of the way. Talk to a friend or a close family. Make them healthcare surrogate. Let them know what your wishes are, so they can think in your shoes. So when you're on the vent, God forbid, with COVID, and especially with pandemic, I think it become more important, more urgent to have your not only your living will, but your financial will in order, so the loved one don't have to go to probate and courts and waste time and money when they're grieving. What's your take on that?
Yeah, absolutely. And now more than ever, it's so important to have in writing exactly your wishes. I always tell my patients, you want to make these decisions now when you're able to make them. When you have a say on how things are going to go down once you are on the process of dying. Because if you leave it to somebody else to guess what you have wanted, chances are that things are not going to go the way you wish, right? And at that point, you may not be able to make your own decisions. That's why somebody else is making them for you. So I can tell you that I have my will, and in that will, everything is spelled out, including whether I want feeding tubes or not, including like how long I would like to be on life support if that were ever to be the case. And also, everything to the burial. Okay. And I'm in my 40s. Okay. So there's no age restriction to do that. And certainly the older you get, the more pressing it is to get this done. So it is important to also choose who would be that decision maker. So if you're married, by default, your spouse will be making decisions for you. But you can override that by, obviously discussing with your spouse, because you don't want your spouse to find out a little too late that you didn't choose them for that. But, maybe your spouse feels like, I couldn't really make those decisions for you if I were to find you on a ventilator or kind of, unconscious. And then you find out, well, maybe my sister can make those decisions for me. And you have that conversation. Your sister understands where you are in terms of your wishes. You have a very thorough discussion. And your sister can be your healthcare surrogate. So this is totally separate from finance. We're talking about specifically who will make decisions when it comes to healthcare about your health, and how things will go down if things get complicated here at the end of life. So it's super important. It's a very simple paper, an advanced directive. And if, you need a surrogate, just make sure it's notarized. So it's a legal paper, but please do so, sooner rather than later, because especially again in the time of a pandemic, I have seen very young people unfortunately passing, and then there are life situations that have always existed. If you look at the chart that Dr. Mahajan presented earlier, the third cause for death in the United States in a very high rate are accidental injuries. So, we have to be ready.
Yeah, that's a great point. I think Kathy brought another important point that she was a disaster nurse for 15 years, and she's thankful for her training because she's dealing with a husband with Alzheimer. I didn't want to bring up, but she brought it up. So I'm glad you brought it out, Kathy, and our prayers are with you. You're a strong person and you have the right experience. He's very lucky to have you on his side, and and it's so important to have the resources discussed, and she has it down pat. She knows when to get him in palliative care, when to get hospice involved. Unfortunately or fortunately, they travel to Canada, so that makes it a little bit more complicated for them. All right, let's talk about the next disease condition, if you may. So we talked about
Mhm.
kidney disease, we talked about cancer. Okay, let's pick up this here. I'm going too fast. All right, here we go. So, the topic, I think it's just, talk about end-stage liver disease, which we have a liver transplant program in the back. And so, we are seeing more cirrhosis and from alcoholic or fatty liver or chronic hep C and different causes. And then neurological conditions, we talked about dementia, but other than dementia, also there are neurological conditions which can make you, bed bound, like Lou Gehrig's disease and MS, advanced multiple sclerosis, Parkinson's disease as it gets more advanced. And there are a lot of other chronic conditions where, you start declining. Um, Tell us how they are similar and different than, rest of the conditions we talked about, Jasmine.
Yeah, so specifically about stage liver disease, very well said. Some patients do come to us actually to hospice while they're still on a transplant list, because as we know, that's a long list, and it may or may not happen before the patient passes. And these are patients that are usually very, very, very ill. So we care for them, and if the transplant comes along, then they get discharged from hospice and they go on happily to have their transplant. But because the chances of that happening, of a transplant actually occurring, are so low, we rather have them under hospice care. And that's something that CMS allows. And most of private insurance follows CMS guidance on these. And these are patients, that suffer from, the inflated belly or ascites. Sometimes they have heart and kidney failure associated with it. So there's a lot of pain and suffering that we can certainly help mitigate, and also help them with the counseling that it's very much needed when you're sort of in the mix of like, am I going to survive this or not, because I'm here in this transplant list. But also patients who are just not in a transplant list and have reached that end stage with the liver, and we can certainly take care of them. And there are a good number of the patients we see every day. Unfortunately, in our county, we see a lot of young patients in their 30s suffering from these. The other diseases that I mentioned, because I didn't want to miss them, were neurological conditions. We do care for patients with ALS or Lou Gehrig's disease. And these patients come to us when they're already having significant difficulty breathing. With this disease, you basically slowly lose your ability to use your extremities. And it sort of goes up slowly from legs to upper extremities to where you can no longer breathe on your own, and then you end up on a ventilator. We support these patients at home with ventilators that we provide for them until their time comes. And it's always a very rewarding intervention. These are families that we recognize, the majority of them having to need significant need for bereavement counseling, because it's a slow progression in their disease, and it's very hard to see. And other patients like Parkinson's patients, some of them end up with dementia at the end of life and very difficult to care for. They already have difficulty swallowing. They may have already a feeding tube. They may be bedbound, and we also can intervene there as well. So all those neurological diseases out there that definitely prevent the patient from taking care of themselves and becoming bedbound and limiting their prognosis. Both palliative before the last few months, and then hospice definitely within the last 6 months of life, can help significantly.
I was reading through the difference why the Suncoast Hospice, is a bigger organization, more older organization. I know there are other for-profit hospice now in Pinellas County, and I was reading and I was very curious, how do you incorporate these holistic therapies? I was reading that you have aromatherapy, music therapy, Reiki, massage therapy, acupuncture. So walk us through, how you incorporate and which patients you use those, and is it covered by hospice, or you charge separate for that?
Yeah, our hospice patients can enjoy these alternative treatments all within their hospice plan of care and at no charge. So aromatherapy can be brought to their homes, or if they're at one of our care centers. And our home health aides are trained into the right kind of aromatherapy to bring under the nurse's supervision. And there's also Reiki, and we have Reiki volunteers through our grant. We have trained a significant amount of volunteers. I am one of them, although I'm not a master. But yes, so Reiki can be offered, can be requested by the patient or the family, and it can be a volunteer coming home to provide Reiki services or at one of our care centers. We also have acupuncture. We have Barbara DeBron. She's a DNP and specialized in acupuncture, and she offers that at our Roosevelt Center here in Clearwater, and the patients come to her clinic and they love it. I've had patients that have canceled all visits just so that they can make it to Barbara's appointments, because they find her help not just through the acupuncture, but just how wonderful she is during their visits and how supportive she is. So massage therapy is also offered. Again, any other alternative treatment. Something interesting, weighted blankets, and this is something that we've been studying in our patients. We just got an IRB approval to formally study the outcome of use of weighted blankets in patients who are restless, who have anxiety, or who have pain, to see if they help comforting them and decreasing the need for medication. So we're all for it, for sure.
Yeah, I bought the weighted blanket from Costco about a few months back, and it was too difficult for me. It was kind of, I think I'm kind of rested personality, but I gave it to my younger son. He loved it. So
yes, my 15-year-old swears by his weighted blanket. Yeah, and he's like a restless sleeper.
So that's if I'm a firm believer, Dr. Martes, in doing things other than medications. I think medications are fantastic, to a certain point, but certain conditions like chronic pain condition, for example, chronic lower back pain, for example, you push the envelope with the narcotics, then you have another problem at your hand is addiction, and the side effects of the narcotics, how they change their mental health, how they become constipated, how they lose weight, how the only thing they think about is when is my next dose coming. And you don't want patients to be in that state by pushing the narcotics so hard. So I think it's great that you guys have acupuncture and Reiki and other holistic methods to help them with chronic pain. It doesn't mean that you tell them to suffer, but a lot of it is mind over body too. That if you can train their mind and give them alternate methods, and we, for example, do the breathing exercise. I'm a big fan of breathing exercise, and I think all those things, meditation, chanting, prayers, they have beautiful effect on how you cope with not only pain but any end of life stress. And there is a lot of stress that you're dying, and and spiritual help is fantastic. So you guys have chaplains of different faiths. How does that integrate? Walk us through.
Yeah, so we call them spiritual care coordinators, because that's what they do. So if a patient requires and requests a chaplain, they will come and visit with the patient and or the family, see what their needs are, and many times it's simply connecting them to their church, maybe because they've been, maybe not frequenting the church as they've been sick and they just want to reconnect. We certainly have very strong connections to all denominations here in town to make that happen. Also, for those who are non-believers and just want to have a conversation about spirituality at the end of life, which happens, so they're of great support, and they're definitely non-denominational in the sense that they're not going to push any particular religion. It's just sort of facilitating what you need at that moment and making it happen. which I think is very integral. It's part of that hospice philosophy where we do believe in treating the patient not only for their physical pain, but also their psychosocial pain and their spiritual pain. And if we can achieve that, then definitely our job is done.
Great points. And Terry is a great listener with his wife, Loretta, and he has a good point. He says, both my parents were hospice, they were morphine, and did that slow down their heart rate before their time? Terry, that's a good point. The narcotics can slow it down, but at that point, what we are doing is we're not monitoring the vitals. What we're looking for is quality. Are they suffering? Are they anxious? Do they have secretions? How it happens has not much bearing physiologically. We don't. In my practice, if I have for example, okay, let's talk about that, Dr. Marcus. So if you have a patient in the hospital and they are, probably have a day to die, and the family wants them, keep them comfortable. I just want to discuss with you and rest of the public. Since I go to the hospital, so I know that's an option available. They can stay in the hospital if they have just a day or two, and to die, and that way they're not moved to the care centers, and that's when we use morphine and Adivans. And I tell my nurses not to bother check the vitals. Why disturb the patient and the family in their last hours or minutes or days? So it does not help you make any changes. You just want them to be comfortable. Anything you want to add to that?
Yes, and Terry, thank you so much for bringing that up, because I think it's a certain concern for many patients and families, one that sometimes even prevents people from coming to hospice. So not every patient in hospice receives morphine. So that's a myth, right? Or any related medications. And as we mentioned, there are other alternatives to treat pain and discomfort. But something that I do like to explain when I come to see a patient and how we can help them, and maybe not at that time, but maybe when things get a little worse down the road, so that I can understand their wishes, is that, when the end is coming, when death is coming, you may need, you can go in two different ways, either kicking and screaming in a lot of pain, or short of breath, or anxious, or that process can be eased by the use of medications. Sometimes there is a trade-off, right? It's a trade-off, and we call it in medicine double effect, which is we are really seeking comfort in symptoms that are considered very difficult to treat any other way. But by doing so, yes, certain vital signs may change, but the ultimate goal, which is more important at that point, is to make sure that that person goes without suffering. And there is a very methodic way to go about it. We don't just go and pour, right, Dr. Mahajan? You just don't go and do one dose size fits all for everybody. It's very patient dependent. We will start with the smallest dose that will cause the best effect, and then titrate that and go up depending on the patient's needs. This can be done in the hospital. This can be done in one of our care centers. It can be done at home. We've had patients in hospice for 6 months on morphine and still not passing, because again, it depends on what stage in their disease they are. But there's also a lot of guilt. Some people feel like, I gave that dose of morphine and that's when my loved one died. Well, the reality is no, they were in the process of dying. The morphine didn't change that process. The morphine made that process a lot easier.
Yeah, that's a very important point, that morphine unfortunately has been linked with hospice care, and it's a great tool, and like any other tool, you want to use it judiciously, and it's not, as you said, use all the time. But if you need to use it, there is no stigma that you can't change someone's dying by a second. It's when the good Lord wants them, they have to go. They have to go. Morphine or no morphine, as you said, our patients, we're given high doses of morphine and Ativan, and they linger for days. So you can't change. And then the family should not have that guilt in their head that, they called the hospice and they gave the morphine, and that caused the death. That's not the case. The case is anytime you come, you have to go, and it's predetermined. And what matters is quality at that point.
Right, and I wanted to add that we're privileged as a country to have these kinds of tools available to us. There are many countries where these narcotics are completely out of reach for dying patients. So the fact that we have that as an option that we can take or leave is a great thing.
Yes, and Lindy is saying thank you for the great info, Dr. Martes. I second her. Dr. Martes did a great job today and brought a wealth of information. Anything? Let me just bring one more slide, and then we'll get your final pulse of wisdom, Jasmin. Here we go. So as we alluded to, that the hospice or palliative care or end of life care can be done in different settings. It could be at hospital, like I was saying, level 4. If they are eminent and don't have a whole lot of days or hours, then we don't have to move them out of the hospital, and they can stay under their primary care, and that brings some continuity to the patient and family. So that's one option. Home is the best option if they are well equipped or have support at home with family and loved ones, and who can handle the end of life, because end of life is very difficult for certain loved ones with the guilt and a lot of other emotional aspects attached. So the home is best, but it's not for every family. And then facilities could be assisted living, could be nursing homes, could be any facility. And then the last, which they have 3 centers, Empath Health. One is the oldest one, the Woodside, the original one in Pinellas Park. And then they have one in Palm Harbor. And then Dr. Martes just told me, I don't go there, but she just told me they have one 12-bed attached with Bayfront Hospital. So they have 3 hospice care centers. Dr. Martes, anything you want to add to the care center aspect? How they are different, and why some of because a lot of patients don't know much about they have not have experience of hospice and the care centers. So maybe you want to talk a little bit about how the care centers approach end of life.
Sure. So the majority of our patients, about 96% of our patients, are taken care of either at home or at a facility where they reside. And we do so with the intense intervention from the interdisciplinary team of nurses, aides, chaplain, social worker, physician. But a small percentage of patients that are either just coming from a hospitalization or very ill in the hospital or closing to passing with a lot of symptoms, or they are at home and then suddenly develop symptoms that are very difficult to treat at home. And as you said, maybe the home setting is not the right setting to treat these symptoms because they may not have the loved one around 24/7 to provide the medications until the symptoms get better. We bring them to one of our 3 care centers. 2 of them are freestanding, one in Palm Harbor. If you live nearby, you probably pass by there often. And that one has about 30 beds, one at Pinellas, which is Woodside, with about 30 beds, and we have one with 12 beds at Bayfront. These centers have been essential now in the COVID era to host our patients and care for them without having to send them to a hospital, right? So our patients receive intense treatments, whether they need pain medications via IV, treatments for respiration, for pain, for bleeding, or for many other potential symptoms. So they are very special places with absolute specialized nurses that all they do is take care of hospice patients along with specialized hospice physicians inside. So they're very special places. They're for a very short term. So it's not for your loved one to move there and stay there until they die, but mostly to just go there until their symptoms are controlled. Many of them, because they come there really, really ill, end up passing in place. And we just facilitate anything that needs to happen after they're passing, including, calling the funeral home and everything that needs to be done. The visitations have been as restricted as they have been in other places with the pandemic. However, lately, we are now again welcoming families to come and visit their loved ones, 1 or 2 at a time, to be there with them, because we do understand how important that is for the well-being of the patient as much as it is for the well-being of the family member or the caregiver.
Yeah, that's, I found a lot of families thank me, if they are in the hospital and their loved one is dwindling and not doing well, and they made a decision about hospice, but they are not ready to go take them home. And we send them to hospice care center, and all of them come very satisfied with the care provided by the team you guys have up there. So you guys do a fantastic job. Any final words of wisdom before we get to our breathing exercises, Jasmine?
Um, one thing that I have to say as a hospice provider is that this is where my heart is. I am very glad that I am providing hospice services to our patients. I can go on the same day to a lavish, beautiful home, to then the indigent, literally taking care of patients who are under a bridge or in a very difficult situation, and they all receive the most compassionate and state-of-the-art care, no matter who they are and where they are. And I think that makes us as a nonprofit organization very special. We really provide a beautiful service to our communities and our families and our friends of our patients. We're also glad to be there early on in the disease so that we can really learn what the patients and family needs are. When I saw Andrew's comments about how hard it was to lose her dad, all I can think is, it's very sad to hear that, but at the same time, I hope she did get the support with Philippine services and the community and the loved ones to support her get through that. And that is something that hospice can identify early on as soon as they meet you. Is it's going to be a complicated grief? Do we need to intensify the visits and the care at this point so it's a little less painful later on? And, if you have any doubt or any question whether your loved one could benefit from hospice, or you yourself because you're going through an advanced illness, discuss it with your physician, of course, have that conversation. And we can have our liaison also do what we call informational visits, just to go over what we can provide in terms of services, and even a direct call, like Dr. Mahajan can call a direct line that we have to discuss one-on-one with one of our physicians or myself. Is this patient appropriate for hospice? So you can get your answers as soon as possible. We are happy to help.
Thank you, Dr. Martes, and keep up the good work. And we're going to be needing your services, for time more for the long time to come, because unfortunately the death is a difficult, emotional, complex things for families to deal with. And you guys help them with those important last hours, and I think it's a beautiful service you provide, and it's very meaningful to the family. So keep up the good work. I must be difficult job for you, to deal with people who are end of the rope and they're dying, but the satisfaction you must be getting must be profound. Must be a lot of burnout in your industry as well, I'm pretty sure.
Yes. Well, somebody has to do it. I'm very glad to be doing it.
Thank you, Dr. Martes. Hang out. We're going to be doing an alternate nostril breathing today, and stay safe.
Thank you for having me.
All right, guys. So we're going to do a quick raffle for the Publix gift card, the $25. I know that's why you're waiting so long. Otherwise, Dr. Martes was so boring. No. So let's bring the drum roll, and let's give the $25 gift card to everyone who put a comment in Dr. Shetty's wonderful talk on chronic kidney disease. So let me roll them around so I don't pick my favorite patient here. All right, here we go. Let's see who we got today. Okay. Let's see who is the lucky winner. So you'll be getting the $25 gift card. And if you put comments, everyone who put comments today, they will be enrolled automatically in our next podcast. Will be next Thursday at 4:30. We have don't worry, I got this shit in front of me, but I don't want to say it till you hear our next guest. So our next guest going to be, a insurance rep. The open enrollment is coming, and she has a lot of um, experience with Medicare Advantage plans, and she can answer your questions about open enrollment. So do stay tuned in for the next Thursday at 4:30, and do comment on today's podcast as well, so that you could be in for the next Thursday raffle. So let's see who's the winner now. So we have Marsha Daly Kennedy Shelsman. So congratulations, Marsha, and you won $25 gift card. Let's go to the breathing exercise today, and then we'll be done for the webcast today. So today's breathing exercise is alternate nostril breathing. The alternate nostril breathing is also called Nadi Shodhana Pranayam, and you use your alternate nostril to breathe in and out, and then you block the other nostril. For this breathing, you have to sit up straight and keep your spine long, keep your jaw relaxed, and then you put your left hand on your left knee, facing the palm up, and then touching your the index finger with your thumb, make a kind of a circle, have the tips touch. So the palm should be facing up on the left hand. And then you bring your these two fingers, the index finger and the middle finger, and touch your forehead gently, and then touch your right nostril with your right thumb and your left nostril with your left ring finger. So that's the position. Now you breathe out and close your right nostril and breathe in through your left nostril. And then close your left nostril and breathe out your right nostril. And then breathe in through your right nostril. And close that right nostril and breathe out through your left nostril. So that's one cycle of alternate nostril breathing. Sound lot of moving part, but if you remember the one which you did inhalation, just close that nostril right after that. So, this is what we call alternate nostril breathing. If you can do 10, 15 times, 3-4 times a day, it will improve your concentration. It will help you calm you down, help you relax. If you do it before you go to bed or before you meditate, it will help you focus better too. It also helps if you do it consistently for month after month to improve your lung capacity. Now, if you want to make it a little bit more advanced, start counting. When you're breathing in, count till 4, and then when you're breathing out, count till 4. So that's if you can keep it track. And then if you become more comfortable with the left and right hand coordination and the counting of 4 on inhalation and exhalation, you can make it a little bit more advanced by counting till 4 on inhalation and counting till 6 on exhalation. Do that for a few weeks. Once you get comfortable with that and you're really doing well with your practice, then you can in maybe 3 months down the line, you can count 4 on inhalation and now double up the count 8 on exhalation. Again, do it slowly. Make sure you're not dizzy, make sure you're not winded, make sure you're not making any sounds when you're breathing. It should be totally relaxed kind of thing. Patty had a comment on our breathing pranayam. Patty, thank you, Patty. She's saying that these breathing practices are great. I hope all of you guys who are regular listeners are not just listening and putting comments for $25 gift card for Publix, and you're actually practicing the breathing exercises, which is one of the key thing I want to bring to your life. With that, we come to the end of the show today. Do tune in next Thursday. We're going to have the insurance agent, Jenny, and Jenny is very knowledgeable in all the matters related to Medicare Advantage plan, as the open enrollment is going to start in October. So you guys should, if you're turning 65 or changing your insurance, do tune in for that show, and you will get a lot of your question answered. And you can put in the comments; you will answer them live. With that, I appreciate you coming in and watching our show. And I appreciate Dr. Martis giving us beautiful information on hospice, palliative care, and different conditions where it applies. If you came late or you're watching later, just tune in. And these shows, by the way, are catalog on our Mahajan Medical Center YouTube channel. You can go there and watch any of the previous shows if you want to refresh your memory, you missed something, or you want to send the link to one of your friends if they're diabetic or they're demented or their loved one is dealing with dementia. All those topics are stored and cataloged on our Mahajan Medical Center YouTube page. While you're there, do subscribe. That will help us know that you guys are taking advantage of it. Do share this webcast with your friends and family if you found it interesting or you think it will be useful for them. And be nice to yourself. Smile in front of the mirror when you get up and throughout the day, and pat yourself on the back. And you are a good human being. Be nice to your friends and family, your fellow human beings, and to the biosphere and Mother Nature. Ciao. And we'll see you on next Thursday at 4:30 with Jenny, our insurance broker. Namaste.